appendicitis is one of the most common surgical emergencies, but its management has been the subject of several controversies over time. These controversies stem from evolving evidence, technological advancements, and differing clinical practices. Below is a detailed overview of the key controversies in the management of acute appendicitis. 1. Non-operative management versus surgery. Background. Traditionally, appendectomy has been the gold standard for treating acute appendicitis. However, non-operative management, NOM, with antibiotics has gained attention as a possible alternative, especially in uncomplicated cases. Arguments for surgery. Removes the risk of recurrence, ensures a definitive cure by addressing the underlying pathology, avoids complications like perforation if antibiotic treatment fails. Arguments for NOM. Avoids surgical risks such as anesthesia complications, infections, and adhesions, especially relevant for high-risk surgical candidates or resource-limited settings. Evidence. Studies like the APAC trial showed that NOM can be effective in about 70 to 85% of uncomplicated cases. However, long-term recurrence rates remain a concern. 2. Laparoscopic versus open appendectomy. Background. The advent of laparoscopic surgery has revolutionized appendectomy, but debate persists regarding its superiority over the open approach. Arguments for laparoscopy: shorter hospital stay, reduced postoperative pain, faster recovery and return to daily activities, better cosmetic outcomes. Arguments for open surgery: simpler and less expensive, particularly in resource-limited settings. Comparable outcomes in uncomplicated cases, easier to perform in cases of generalized peritonitis or complicated appendicitis. Evidence. Meta-analyses generally favor laparoscopy, but the choice often depends on surgeon expertise, patient factors, and resource availability. 3. Management of complicated appendicitis, e.g. perforation or abscess. Immediate surgery versus interval appendectomy. Some advocate for immediate appendectomy in cases of perforation or abscess, while others recommend initial non-operative management with antibiotics and drainage, if necessary, followed by interval appendectomy. Arguments for immediate surgery. Definitive treatment. Prevents recurrence or progression of the disease. Arguments for interval appendectomy. Allows inflammation to subside, reducing surgical risks. Some studies suggest interval surgery may not always be necessary, as recurrence is not universal. Evidence. There is no consensus, with practice varying based on institutional protocols and patient presentation. 4. Role of imaging in diagnosis. Ultrasound, CT, or MRI. The role of imaging in diagnosing acute appendicitis is debated, particularly in children and pregnant women. Arguments for routine imaging. Reduces negative appendectomy rates. Helps differentiate uncomplicated from complicated appendicitis, guiding management. Arguments against routine imaging. Increases healthcare costs, risks associated with radiation exposure, CT scans, or limited availability, MRI. Evidence. Imaging is increasingly used as standard practice, particularly CT in adults and ultrasound in children, with MRI reserved for specific populations. And 5. Antibiotic duration and choice. Controversy. The optimal duration and type of antibiotics for both uncomplicated and complicated appendicitis are debated. Uncomplicated cases. Single-dose prophylactic antibiotics before surgery are standard, but some advocate for a short postoperative course. Complicated cases. Duration ranges from 3 to 7 days postoperatively, with some advocating for tailoring therapy based on clinical response. Evidence. Studies suggest that shorter antibiotic courses, 3 to 5 days, may be sufficient in most cases, but definitive guidelines are still evolving. 6. Management in special populations. Pediatric patients, greater reliance on ultrasound for diagnosis. Higher concerns about long-term risks of radiation with CT imaging. Pregnant women, debate over imaging modality, MRI versus ultrasound. Greater caution with surgical timing and approach, laparoscopy versus open surgery. Elderly patients, high rates of atypical presentations and complications, making diagnosis and management more challenging. NAR 7. Cost-effectiveness of different approaches. Debate persists over the cost-effectiveness of NOM, laparoscopic surgery, and advanced imaging modalities. While newer methods may improve outcomes, they also increase costs, raising concerns about accessibility in resource-limited settings. 8. Negative appendectomy rates. Despite advances in imaging, a small proportion of appendectomies still reveal a normal appendix. The acceptable rate of negative appendectomy and strategies to minimize it, e.g., universal imaging, remain debated. Conclusion. The management of acute appendicitis continues to evolve, driven by advances in technology, research, and changing patient expectations. While there is growing support for individualized treatment approaches based on patient factors and disease severity, many controversies persist, emphasizing the need for further research and consensus building.